Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. Here in this particular weekly booster class, I am discussing those very important golden questions which all are very different from the regular. Students, by assessing the last 3 to 4 Norcet exams and other exams, there are fixed 1 to 2 or sometimes 3 questions which are coming from the interpretation of the X-ray, some radiological signs like steeple sign, thumb signs, okay, target sign. So these all are the very important signs and which all are very easy to identify. Okay, but some of the nursing students don't know about the radiological signs. So, in this particular very important weekly booster class, I am going to fix your 2 to 3 marks for your upcoming Norcet exams and other all state and central government exams. So, all you people have to do while watching this class is to take a notes of this one, identify the things where I am highlighting. Okay, so take a screenshot of the X-rays and save in a particular notes in your mobile. Okay, so wherever the assignment I am assigning to you people, so please do follow that one. Okay, so because I am telling you the a very important thing and rank deciding thing. Okay, so with this particular very important beautiful motivational quote, we will start the today's class. Don't follow the crowd. Students, always you have to be a different, you have to do something different to get the best rank. What actually the toppers are doing, what actually they are learning, so you have to go till that extent to get the better ranks. Yes, almost all of you are get qualifying with a 2000 rank, 3000 rank, 2500 rank, and at the end you are landing with the lack of the seat allocation in the your AIMS exams and other exams. So I want to fix your those very hard level and medium to high level questions in the Monday booster class. So this is the first Monday booster class. Just I am posting this one in the app also and in the YouTube also. Okay. Why? Because I want to show the sample how actually it is worthful and how actually it is beneficial to the aspirants. All right. So we'll start the today's class and just think, don't always follow the crowd, because the following the crowd will not give you a success. If you are doing something great, you are learning something beneficial, then only the rank will comes to you. Okay, so stay true to yourself, always trust on yourself. Okay, so always think in yourself. Okay, it will build the self confidence and definitely it will give you a best rank, right? So with this beautiful motivational quote, we will start the a very important question. Okay, so the question is very simple here. The thumb sign on the lateral neck x-ray is most commonly associated with which condition? The thumb sign. Okay, where it is getting when we will take the a neck x-ray in the lateral position. Okay, so usually we will take the x-ray in a posterior anterior view, anterior posterior view, lateral view. Okay, so here we have taken the chest neck x-ray in the lateral view. Okay, so here we are able to get the a thumb sign. So it is actually most commonly associated with which of the following condition? I want answer from every one of you. So फटाफट try to give the answer to this particular very important question. Option A is the epiglottitis, option B is the Croup, option C is the retropharyngeal abscess, and option D is the peritonsillar abscess. Yes, so this question coming in the exam means every one of you will choose the correct answer, that is the epiglottitis. But if this x-ray comes in exams, many of you will get confused what it is actually. Bachcho, focus at this particular area. Okay, whenever there is in the lateral neck x-ray, so always first try to identify the epiglottis. Okay, so here the epiglottis is not in normal size, it is somewhat big. Okay, so this is the epiglottis which is actually big here. Okay, okay, so here which is looking like a thumb. Okay, it is looking like a thumb. So when we will take a lateral neck X-ray, it is looking like a thumb. So we will say this one is in the thumb sign, which will be a classical sign of the epiglottitis, which is a infection and inflammation of the epiglottis. Okay, so let us discuss some golden words about the epiglottitis. So epiglottitis is an infection and inflammation of the epiglottis. Okay, here we will see the classical 4D sign. Okay, so what is the classical 4D sign we will see here? So the classical 4D sign here, first one is the dyspnea, means there is a difficulty in the breathing, and the second one is the drooling. Okay, there is continuously salivation coming out of the mouth. And fourth one is the dysphagia. And most importantly, fourth one is the dysphonia. Okay, means there is a change in the voice. Okay, so there is classically voice comes here as that is the potato mushy voice. Okay, so what we can say, this one as in the potato mushy voice, or we can say the hard potato voice. Okay, so in the dysphonia, which one we will get classically, that is the hard potato voice. Write it down, bacho, it's very important. Hard potato voice. The most importantly, where we will see the hard potato voice, we will see in the case of the epiglottitis. Bacho, it is very important. And write down the most common cause for the epiglottitis is, yes, can anyone want to tell the answer? What is the most common sign for the epiglottitis? Yes. So previously it was the Haemophilus influenza type B. So because of the vaccination, it is decreased. Now the most common site of the epiglottitis is streptococcus pneumoniae. Okay, so streptococcus pneumonia is the most common sign of the epiglottitis. So hope all these golden points are helpful to you people, right? So hope it is clear. Answer for this particular question is clear. And here is the next question. So please do read the question carefully, completely, and try to give the best answer. The question is very simple again. Again on the radiological sign, the steeple sign seen on the anterior-posterior neck X-ray is characteristics of which pediatric condition? The steeple sign. Okay. So what is steeple sign? Steeple is like what we can say, it's in the upper portion of the church. Okay, and on the church you people have seen, this is the upper portion of the church. Okay, which looks like this. Are you able to see this one? So this image, so this is what you call the steeple. Okay, so here when we see the anterior posterior neck X-ray, here also we are getting the steeple sign of the trachea and bronchi. Look at this one, bacho. The bronchi is like it is getting sharp here. Okay, like this. So this thing we are getting means it is a classical sign of the our conditions called as the Croup, or we can say the laryngotracheobronchitis. The question will comes, what are the things which comes in the Croup? Okay, so in the Croup it will comes as a most important one, that is the laryngeal infection inflammation, and a tracheal infection inflammation, and bronchial infection inflammation. Okay, sometimes the examiner give which of the following is not a part of the Croup, and in that one, so he can include the pharyngitis also. Okay, so pharyngitis is not a part of the Croup. Okay, so it is a LTB. Okay, that is the lungs TB. You can remember laryngeal, tracheal, and bronchial infection inflammation. So we can say this one is in the laryngeotracheobronchitis or the Croup. In the Croup, the trachea looks like this as a steeple. So on the anterior posterior neck X-ray, okay, so we are getting the steeple sign, means it is clearly indicating the crop. Okay, so hope it is very much clear to you people. Okay, so in the crop we are having the classical sign of the barking cough. Okay, barking cough is a classical sign of the crop, and entire thing we will discuss in the in detail study of the crop. Okay, the pediatric teacher will tell you what actually it is. Okay, so look at this one. This is the steeple sign. Okay, so again here is the big X-ray. Okay, which is showing you a steeple sign here. Okay, so hope it is clear. If it is not visible properly, so please improve your the video qualities. Okay, because we are studying the X-ray here, so it requires the clear video quality. Okay, so this is what we call as the steeple sign, which happens because of the subglottis narrowing. Okay, so below the glottis there is complete narrowing of the larynx, trachea and bronchi. So that is the laryngeotracheobronchitis. Okay, so here subglottic narrowing in the Croup, we call that one as in the steeple sign. Hope it is completely clear to you people, right? So here's the next most important question, and very very important question. Okay, so the double bubble sign. Okay, so the double bubble sign in an abdominal X-ray, when we will take X-ray of the abdomen, so we are getting the double bubble sign is the most characteristics of the which of the following condition. So among given all these condition, which of the following is a most important condition where we will see a double bubble sign? Option A, Hirschsprung's disease. Option B, double duodenal atresia. Option C, intussusception. Option D, hypertrophic pyloric stenosis. Yes, so double bubble sign is a classical sign of the duodenal atresia. Okay, so we will see if the question is coming like this, almost all you people will answer this one is in the double bubble sign as a duodenal atresia. When the examiner will show you a X-ray, so that time you people will get confused. Okay, so here look at this X-ray particularly. So this is the actual stomach, esophagus, stomach, and this is the duodenum, right? So this is actually how it should be normally present. But here in the duodenal atresia, there is a separation of the stomach is there, then complete atresia is there, then duodenum is there. Okay, so here this is becomes a stomach bubble, and this is becomes a duodenal bubble. So one bubble, two bubble, that is the double bubble sign which will be seen in case of the duodenal atresia. Okay, so here is the complete absence of the lumen between the stomach and duodenum, that is the duodenal atresia, so which classically indicates the duodenal bubble, stomach bubble. So this is the double bubble sign, so seen in case of the very very important duodenal atresia. Most important question. Okay, most important question. So then comes to this particular X-ray. Look at this bacho, the stomach bubble is there, duodenum bubble is there, jejunum bubble is there, means so this is what we call as in the triple bubble sign. Okay, this is what we call as the triple bubble sign. So this triple bubble sign is classically indicates the jejunum atresia. Okay, jejunum atresia. Very very important. Okay, so here's the next very important question. The question is very simple and most important. The string sign on the contrast of the upper GI study is most commonly associated with which pediatric condition? First, we will discuss all the pediatric condition because these are the high yield questions. Then we will go for the adult conditions. Okay, so don't worry about that. So string sign on the contrast upper GI, which indicates which of the following condition? The string sign is classically indicates the hypertrophic pyloric stenosis. Okay, so many questions have arises from this particular question of okay, the hypertrophic pyloric stenosis. Okay, the projectile vomiting, non-bilious vomiting. Okay, so this kind of the questions repeatedly arises. There is chance of the arising the radiological based questions also from this particular hypertrophic pyloric stenosis. So we have to study this one in detail. Okay, so what is actually string sign? String sign is the like a like string means here is a dhaga. Okay, what we can say, okay, in kannadadalli ನಾವು ದಾರ ಅಂತ ಹೇಳ್ತೀವಿ. So ಇಲ್ಲಿ it looks like a string. Look at this particular image, bacho. So here a child is there. Here we have given the upper GA contrast to the chemical which came inside here. Okay, so now the contrast is here. Okay, this is the stomach. Entire stomach is filled with the contrast, so it is looking a complete bright white. Okay, so here is the stomach and here is the pyloric sphincter. Look at this particular portion here. Here only a small white portion is there. Okay, so which is like a dhaga, or we can say the dhara. Okay, so which is looks like a string. In English we can say this one is in the string, right? So the completely it is like this. Okay, then it is very narrowed. Okay, then there is the normal duodenum. Okay, means here it is in the due to the excessive hypertrophy of the pylorus. Okay, very small opening is there. Okay, so very small opening is there. So this small opening what we call as in the string sign, which will be classically seen on the hypertrophic pyloric stenosis. The most important question which may strikes in your upcoming exams. Okay, so hope it is completely clear to you all, right? So here is the next very important question, that is egg on string sign. Okay, so egg on string sign appearance in a chest x-ray. In a chest x-ray is the most characteristics of the which of the following congenital heart disease. Okay, so egg on string sign in a chest x-ray is most characteristics of the which of the congenital heart disease. Option A, that is the tetralogy of the phalate. In the tetralogy of the phalate, we will see another type of the classical X-ray finding, not a egg on string. Okay, so option B, transposition of the great arteries. Option C, total anomalous pulmonary venous return and truncus arteriosus. Egg on string sign is a classically seen on the the transposition of the great arteries. What it means, sir? Transposition of the great arteries, what it means, sir? Look at this image, particular image, bacho. So this is the our, what we can say, the left ventricle, and this one is the our right ventricle. From the right ventricle normally there should be a pulmonary artery should arise, but look at this one. From the right ventricle here the aorta is arising. Okay, and from the left ventricle normally should a aorta should arise. Here look at this one, the pulmonary arteries are arising, means a two arteries. Actually this aorta should arises from here and this pulmonary artery should arises from here, but it is happening opposite. So here the transposition means opposite position of the great arteries. Great arteries are two arteries are there, that is the aorta is the great artery and a pulmonary artery is the great arteries. These both arteries are transpositioned. Okay, so which are not in the normal position, which is changed the position. Okay, which is a congenital heart disease. Okay, so here we will see a egg on string appearance. Okay, look at this one, a big egg like opening. Okay, because of the arteries displacement, plus here's a dhaga, or we can say the dhara, or we can say the string. Okay, so look at this one, this is the egg and which is tied by the a string. Okay, so this is what you call as in the egg on string appearance, which is a classically seen as a chest x-ray in a case of the transposition of the great arteries, which is most important for your upcoming exams. Okay, so here is the next most important and very easy and important question, that's the a boot shaped heart. Okay, a boot shaped heart, or we can say the coil and sabut. Okay, so appearance on pediatric chest x-ray is most commonly associated with which of the following heart defect. Okay, so boot shaped heart or the, so what we can say, the coil and sabut. Okay, so this particular type of the x-ray where we can see option A is the ventricular septal defect. Okay, option B, tetralogy of the phalate. Option C, Epstein's anomaly. Option D, transposition of the great arteries. Okay, so just we have seen the transposition of the great arteries, so we have to we seen a egg on string appearance. Okay, egg on string appearance. Okay, so this is in the transposition of the great arteries, right? So The what is the correct answer for this one? Yes, almost all of you have chosen the correct answer. Okay, so that is a tetralogy of the phalate, where we will see the classically a boot shaped heart. Okay, so let me comes to the images. So this is the very important image based questions that may strikes in your exam. Okay, so look at this one. In the tetralogy of the phalate, the heart and its vessels looks like a boot. Okay, so this is what you call as the boot shaped heart. So seen in the case of the tetralogy of the phalate. Okay, so seen in case of the tetralogy of the phalate. So hope it is completely clear to you people, right? So what happens in the tetralogy of the phalate actually? Why it is looks like this one? So in the tetralogy of the phalate, listen here. So this is the beautiful heart, right? And these are the walls in the heart. Okay, so here from here the pulmonary artery will arises like this, right? So right pulmonary artery, left pulmonary artery. Okay, so and here the aorta will arises. Okay, from here the aorta will arises like this. This is a normally what happens, right? So because of the stenosis of this particular pulmonary artery, so pulmonary artery is very much stenosed here. Okay, and there is no proper opening. It is completely stenosed. Okay, which is completely stenosed. Because of this one, this particular right ventricle need to pump more to push the blood here. Okay, so because of the overload and overwork of the right ventricle, so there is in the right ventricular hypertrophy happens because of the pulmonary artery stenosis. The right ventricular hypertrophy happens and the pressure increased here. Okay, so which allows the blood to move from the right ventricle to the left ventricle. Because of this opening or the hole here, what we can say, this one is in the ventricular septal defect, and so the blood will move from the right to left. So there is a right to left shunting is there, so we call this one is in the cyanotic heart disease, because the carbon dioxide rich blood is mixing with the oxygen rich blood. Okay, so the carbon dioxide rich blood will supplies to the body and whole body become sinusoid. So sorry, this is a not a cyanotic, this is a cyanotic heart disease. Okay, so this is not a cyanotic, this is a cyanotic heart disease. Okay, this is a cyanotic heart disease because of the carbon dioxide rich blood mixes with the oxygen rich blood, and this carbon dioxide rich blood will circulates to entire body, so the entire body become bluish color. So that is the cyanotic spell we can see in the case of the our tetralogy of Fallot. Okay, so now the blood is overloaded here, and the overloaded blood will ride overly over the aorta. So the overriding of the aorta. Okay, overriding of aorta. Listen to the concept here. Because of the pulmonary artery stenosis, the right ventricular hypertrophy is happening. Because of the excessive pressure here, the blood is moving from the right ventricle to the left ventricle, and here the due to the excess overload, so the overriding of the aorta happening. So these four things, first number 1, 2, 3, and this fourth thing. So this all together we call as in the tetra. Okay, tetralogy of Fallot. Okay, so here in a chest X-ray, we will see the boot-shaped heart as a classical one. Okay, and all four components of the tetralogy of the Fallot, the examiner will ask in the exam. So most importantly, how we have to remember this one. Okay, how taught to you people, right? So comes to the image-based question. The boot shape heart, why it will be? Because like this, because of the this particular heart shape. Look at this one. So this is the normal muscles of the right ventricle, but look at this one, the hypertrophy of the normal muscle. So here it is the excessive hypertrophy of the normal heart muscle. So that is the right ventricular hypertrophy, you can say. So which happens because of pulmonary stenosis, right ventricular hypertrophy will happens. So because of that one, the blood will move from the right to left, and there is the overriding of the aorta. So these all together called as in the tetralogy of the Fallot. So this is the most important thing what we have discussed just in the last question, right? So here is the most important question again in front of you people. So please do watch the read the question completely, Then try to answer to the particular question which is shown in front of you paper. Okay, so we'll completely finish the pediatric, very important radiological science. Then we'll go for the adult, where we'll discuss the classical normal X-ray, classical pneumothorax X-ray, classical pleural effusion X-ray, cardiomegaly X-ray. Okay, so X-ray in the COPD, everything we'll discuss. Okay, so first we will see the classical conditions from the pediatric. Okay, so because these are the highest chance of striking in the exams. Right? The question is very simple, very important. That is a figure of 8 or a snowman shaped X-ray appearance, chest X-ray appearance in a pediatric condition is a characteristics of the which congenital heart disease? Which congenital heart disease? The most important question. Option A, tetralogy of the palate. Just we have discussed it. That is the boat-shaped heart. Okay. That is the. Just a second. Boat-shaped heart and its component we have discussed clearly in the tetralogy of the palate, where the figure of 8 will not a part of the tetralogy of the palate. I am eliminating option A. Then comes to the transposition of the great arteries. We have discussed already a transposition of the great arteries. Okay, which X-ray finding will be seen? Yes, look at this one. A gone string appearance in a chest X-ray. Okay, that is the classically seen in the transposition of the great arteries. Already have discussed. So option C I am eliminating. Then the tricuspid atresia, both. So this is not a correct answer. So the snowman or the figure of 8 anomalies. Okay, so figure of 8 appearance will be seen in the total anomalous pulmonary venous return. Okay, so TAPVR. In TAPVR, we will see the figure of 8 or the snowman appearance. Okay, what is actually the TAPVR? Yes, we will discuss here. Okay, but so look at this one particular image, the normal heart. Okay, so here this is the right ventricle, and let me change the pen color. So this is the right ventricle, this is the left ventricle. Okay, so from here the normally pulmonary arteries are arising, and from here the normally aorta is arising. Every one of you know normally. Okay, and so whenever there is a pulmonary artery which supplies blood and pulmonary it will goes to the lungs, and from the lungs the pulmonary veins will come. It will should connect the directly to the only and only our left atrium. Okay, if it is not connecting directly to the left atrium, and which is abnormally going and connecting to the again back to the return back to the our superior vena cava, so or we can say directly to the right atrium sometimes. So this is what you call as in the total anomalous pulmonary venous return. Okay, so totally abnormally pulmonary veins are coming return. Okay, so normally it should be come and connect to the our right left atrium. Okay, so here look at this particular image. So the pulmonary veins which are coming here, okay, abnormally which connected to the here, look at this one superior vena cava, or it may directly connect to the right atrium. So this is what you call as in the total anomalous pulmonary venous return. Okay, so it happens because the upper part of the 8 is happens because of this anomalous connection, and so because of that one total anomalous connection, the excessive blood will comes to the right atrium. The right atrium will get enlarged here. So the lower portion of the 8 which will be made by the that this particular enlargement of the right atrium. So the figure of 8, or we can say the snowman appearance. Okay, so this particular image what we call as in the snowman. Okay, are you see the snowman like this? Okay, so this is the snowman appearance. Look at this one. Okay, the figure of 8, or we can say this particular image. Okay, the snowman image. Okay, which will be seen classically in a total anomalous pulmonary venous connection. So this is the correct answer for this one. Option B, very important question for you all, right? So the next very important question is here: the bird beak sign seen on barium swallow or contrast. study is a most commonly associated with which condition? Okay, we'll study some barium study also here. So some classical signs are here. So just look at the question and try to read the options and try to give the answer. Okay. So bird beak sign, or we can seen in the barium swallow. Okay. On a contrast study is most commonly associated with which condition? Option A, achalasia cardia. Option B, Hirschsprung's disease. Option C, esophageal atresia. Option D, hypertrophic pyloric stenosis. Right? What is the correct answer? A bird beak sign is a classical sign of the yes achalasia cardia. Right? So the hypertrophic pyloric stenosis on the X-ray abdomen, we have studied this one. A string appearance. Right? Right? Then the bird beak sign is a classical sign of the achalasia cardia. Okay, so we'll discuss next this option also in the next questions. Don't have to worry about that. Okay, so the achalasia cardia. Look at this one. When we will allow the patient to swallow the barium, and when we will take the X-ray, so here due to the excessive spasm of the lower esophageal sphincter, okay, only the less portion of the contrast will go down, and which makes like a beak of the bird. Okay, so it makes like a beak of the bird. Okay, this is the bird here. Okay, and this is the eye of the bird, and this is the beak. Okay, so this is what we call it in the bird beak sign. Okay, the bird beak sign is classical seen in the achalasia cardia. So what is the achalasia cardia, bacho? Achalasia cardia is the yes excessive spasm and narrowing of the lower esophageal sphincter of the esophagus. Okay, so let me draw the diagram and clear you people. There are two things. One is the loosening of the lower esophageal sphincter. One is the contraction of the lower esophageal sphincter. Okay, so look at this one. This is the normal esophagus. Okay, so here is the esophageal sphincter, right? So if this esophageal sphincter is widened or loose, so we can say this one is the entire gastric content will returns back. Okay, so that is what you call as the gastroesophageal reflex. Means the gastric content is returning back into the esophagus. GERD. Okay, that is the gastroesophageal reflex disease. Okay, so then the most importantly next one is the this is the normal esophagus. Okay, when the lower end of the esophagus will get contracts. Okay, so this is the contraction of the lower esophageal sphincter and or the narrowing of the lower esophageal sphincter. So this is what we call as in the achalasia cardia. Okay, achalasia cardia. That is the excessive contraction of the lower esophageal sphincter. So when we will introduce a barium here, so here till the here the normal barium will come, and here it will comes very narrow barium, so which looks like a beak of the bird. Okay, so this is a bird. Okay, just wait for a second. Okay, so this is the bird here. Okay, this is the face of the bird, and so this is the beak of the bird. So bird beak sign will classically seeing here in the achalasia cardia. Hope it is clear to you people, right? So here is the next most important and very easy question. The question is very simple, bacho. So please do read the question. The coiled spring sign seen on contrast enema or ultrasound is the most commonly associated with which of the following pediatric condition? Okay, so that is the coiled spring sign, or we can say another sign also for this name. I will discuss with the image in the next slide. Okay, don't have to worry, just try to give the answer for this particular question. Okay, the coiled spring sign seen on the contrast enema in ultrasound. Okay, not in the X-ray. It is in the ultrasound. What is the correct answer? Yes, that is the classically seen in case of the intussusception. What is the intussusception? Intussusception is the telescoping of the one bowel loop into the another bowel loop. Okay, consider. So this is the ileum. Okay, so this is the cecum, and here is the large intestine is starting. This is the appendix. Okay, here is the large intestine. Right here, this particular ileum is telescoping back, means introducing into the a cecum, means a telescoping of the one lobe into the another lobe. Okay, this is what we call as the intussusception. Okay, so intussusception in this particular condition. Okay, so when we will see a particular very important ultrasonograph, okay, it will be like this. Okay, so look at this one. This is the largest bowel. Okay, here the largest bowel, and inside that one there is a small bowel is entered. Okay, so this is what you call as the donut sign, or we can say a target sign, donut sign, or the coiled spring sign. Okay, sometime on x-ray it will be looks directly like a spring also. Okay, look at this one. Okay, so this one is a coiled spring also, we can say, or when you will see here it is looking like a donut. Okay, so on USG it will be clearly looks like a donut. Okay, this is what you call as in the donut sign, or we can say this one is in the target sign, or the donut sign, or the coiled spring sign. So all this will be seen in a case of the into susception. That's the red current jelly stool is a classical sign of this particular into susception, right? So then comes to the chest x-rays. Here in this chest x-rays, we'll study what is the normal chest x-ray first. Then we'll go for the abnormal chest x-rays in detail. Okay, because which are most very important, and in every Norcet exams and other exams, definitely 1 to 2 questions are striking from the chest x-ray, and 1 to 2 questions from the pediatric conditions with radiological science. Okay, so almost very important radiological science from the pediatric conditions we have discussed. Now we will discuss the what is normal chest x-ray, how actually normal chest x-ray looks like, what are the part we have to focus, where we have to focus. Okay, so what is the cardiothoracic ratio. Okay, so what is the costophrenic angle, what is the blunt costophrenic angle, what is the sharp costophrenic angle. Okay, so we'll discuss everything and some abnormal conditions, how to identify with assessment. We will discuss everything in detail. Okay, so just first I will show you a normal chest x-ray. Look at this one. So this is a normal chest x-ray, bacho. Okay, so every common man can identify. Okay, so this is a trachea. Here this is a trachea, right? This is the trachea, this is the right bronchus, and here it goes the left bronchus, and here it is the carina. Okay, so this is how actually in middle the trachea is normally present, and these are the clavicle bones. Okay, so this part is the clavicle bone, this is the clavicle bones. Okay, so when you will see this particular portion, this is the heart. Okay, so which is the heart. Okay, so this particular portion we call as in the cardiac notch. This particular portion we call as in the cardiac notch, because of the there is heart is there, so we call that one as in the cardiac notch. Okay, so this particular portion we call as in the okay, so we can say call this one is in the lingula, because this is the movable portion of the lung. Okay, which moves like a trunk. Okay, so that is the lingula, we can say. So the most importantly, when you see the normal lung fields, okay, where we can see the ribs also on this one. Okay, so when you see the normal lung fields, okay, which is yes, which is black in color, right? So the normal lung is black in color because of the which indicating the air is present inside. Wherever the air is there, so the X-ray which looks like a black in color. Okay, if there is fluid, which looks like white in color. Okay, if there is any metal or the contrast, if there is any metal or if we induced any contrast. Okay, so which looks a bright white, a very bright white. Okay, so fluid looks like white, and metal and contrast which looks like a bright white. Okay, so this particular black is indicating the air. This is the very basic, bacho. You people basically, and you can interpret the X-ray very easily. Okay, so this is the normal chest X-ray, and look at this one, bacho. So whatever this particular white surrounding which is looking here, are you people able to see this one? So this is the pleura and pleural fluid. Okay, just now only I told you people. Okay, so the fluid will be white in color. So around the lung, are you people able to see the white border? So this white border indicating the pleura and pleural fluid. Okay, so at this particular end, are you people able to see the sharp point? So this is what we call as in the costophrenic angle. Okay, what we call this one is in the costophrenic angle. So this is the right side, this one is the left side, the most important thing. Okay, so and below here, here is the diaphragm. Okay, so here is the diaphragm we are having. Okay, so we'll see what is the actual normal position of the diaphragm and all everything. Okay, so when we will see the normal lung fields, okay, so it should be very clear and it should be a symmetrical. Okay, so not one side is big one, another side is a very small one. It should be not like that. Okay, it should be very clear and it should be symmetrical. Okay, and there is no any visible masses here. Okay, are you people any see any visible mass you are able to see here? No, so then it is a normal chest X-ray. Okay, it should be clear, it should be equal and symmetrical, and there is no any nodules masses. Okay, there is no any consolidation. Okay, the vascular marking should be clearly visible. Okay, vascular marking means, are you people able to see? This is also normal chest X-ray. Okay, so here aortic knots. Okay, where the aorta will comes like this. Okay, the aortic knots is there means the vessels should be clearly visible here. Okay, so then the superior vena cava, are you able to see here the superior vena cava entry? So this vascular uh, marking should be clearly visible. Okay, so but not over exaggeratedly visible. Okay, so it should be clearly visible, that's it. Okay, so the most important, the lung field should be clear, lung field should be symmetrical, and there is no mass, no nodules, no any consolidations. Okay, if there is mass, nodules and consolidations, which indicates the consolidation indicates the pneumonia. Okay, masses or nodules indicates the a tumor in the lungs. Okay, so any if field is not clear, so it may indicate the a pneumothorax or hemothorax, whatever it may be. Okay, so then comes to the size and shape of the heart in the chest X-ray. Most important, bacho, the heart size and shape. Okay, so we can say this one is in the cardiothoracic ratio. Okay, look at this particular in normal chest X-ray. This is the thoracic portion. Okay, let me take a different pen here. Okay, so this is the thoracic portion. This is the lungs. Then this is the till here it is the lungs. Okay, and this is the portion of the heart. So normally this portion of the heart should be less than half of the this particular portion of the thorax. What it means? So consider the this particular length of the thorax is 30 centimeter. You consider this particular cardiac length should be less than 15 centimeter, means it should be less than half of the thoracic ratio. Okay, so this is the cardiac thoracic ratio. Okay, so if it is more than this one, this cardiac thoracic ratio is more than half or more than 0.5 percentage more, so we call this one as in the increased cardiac thoracic ratio. That clearly indicates that there is in the big heart. So big heart we call as in the cardiomegaly. Okay, so in normal situation, the heart size and heart shape where the cardiothoracic ratio, okay, so should be less than 0.5% is on the PA view of the heart, means the posterior anterior view of the heart. Okay, so heart border should be well defined and clearly visible, except the right atrium borders will not visible normally. Okay, so right atrium border sometimes not visible normally. Okay, so when we'll take the anterior posterior view of the chest X-ray. Okay, then comes to the right hemi diaphragm is slightly higher than the left side. Okay, so normally the right side diaphragm is slightly higher than the lower side left side. Okay, why? Because At the right side, there is a lever is there, okay, which pushes the diaphragm upward. So normally the height of the right side of the diaphragm is slightly higher than the left side, okay, which is most important. Then a costophrenic angle should be normally it should be sharp, okay. So the costophrenic angle, what I told here, the costophrenic angle, it should be a sharp, okay. So it should not be blunted. If it is blunt, which clearly indicates it is a case of the pleural effusion, okay. So I will tell in detail in the next slides of the pleural effusion. Don't worry about that one, okay. So the costophrenic angle should be clearly, it should be clearly sharp, okay. So the most very important next thing is a trachea, okay, or the mediastinum. It should be in middle, okay. So trachea should be in the center and mediastinum should not be widened, okay. So if the trachea is deviated to the one side, so that indicates the opposite side abnormal things, right. So opposite side abnormal thing is the most important identity. Okay, so what is the tracheal deviation, what is the mediastinal shift, okay, everything we will discuss the most importantly in this particular session only, right. So hope it is clear the normal chest x-ray, okay. All you people have to know very basic is the, okay, air looks black, okay, fluid looks white and metal and contrast looks very bright, okay. So the cardiothoracic ratio is less than 0.5. If it is more than 0.5, that is the big heart cardiomegaly, okay. And the right side diaphragm is slightly higher than the left side, okay. The costophrenic angle should be sharp. These are all the statement all people have to know and remember related to the normal chest x-ray, okay. This is very basic thing I am teaching to you people to identify and answer correctly in your upcoming Norcet exams, okay. So hope it is clear to you people, okay. If you are getting sleepy, getting bored, means do nothing, just study, because you want a job of the 1 lakh per month. So for that one, you people have to struggle like this only, okay. Because in our studies, so here we are giving a spoon feeding to you people. These all things we have studied while our preparation we have studied on our own. Okay. So it took me around 7 to 9 days to understand the entire X-ray, to study after studying the multiple medical books and all. Okay. Because during our preparation, there was no any YouTuber or any a teacher who is studying these things in a free of cost with this particular simple and very easy explanation. So we struggled. So we are giving here a spoon feeding. You people are getting sleepy, bored, means we can't do nothing. So that indicates clearly you are not focused about your dreams or aims. Okay. So if you want to be a boosted champion, winner, or a successful person, so just drink a water, close your eyes, open your eyes, open your eyes, and open your eyes and study. That's it. Right? So the next question is very important and simple question here. The classically, the meniscus sign on the chest X-ray is most commonly associated with which of the following condition? The meniscus sign in the chest X-ray is most commonly associated with which of the following condition? Yes. Fadafat answer please. Option A, pneumothorax. Option B, pleural effusion. Option C, pulmonary embolism. Option D, pneumonia. The answer goes here as the meniscus sign is clearly indicating which is a sign in the pleural effusion. Okay. So let me discuss everything related to the pleural effusion. What is pleural effusion? Pleural effusion is the accumulation of the fluid in the pleural space. Okay. Bacho, very basic thing you people have to understand and identify the difference between the pleural effusion and pulmonary edema. Okay. So this is the trachea, this is the bronchus, and here is the right lung, and here is the left lung. Okay. So this is a very basic structure you people have to understand. Okay. So here we are having the layers around the lungs. We call this one as the pleural layers, right? We call these are the pleural layers. So I am not teaching what are the pleural layers are there. Okay. Just I am giving a clear idea in this pleural space. Okay. So here is the pleural visceral pleura and here is the parietal pleura. So in between the visceral and parietal pleura, here is the fluid. Okay, this is what we call as the pleural fluid. Okay, so this is the pleural fluid. If this pleural fluid excessively accumulating, means which pushes the lung upward. Okay, the lung tissue will go upward. Okay, so this is the normal lung tissue till here, so it will go till here. Okay, so and rest of the area will be accumulated with the fluid. Okay, this is what we call as in the pleural effusion. Okay, so accumulation of the fluid in the pleural cavity, not in the lung tissue. Okay, if there is accumulation of the fluid in the lung tissue inside the lungs, so this is what we call as in the pulmonary edema. Okay, what we call this one is in the pulmonary edema if accumulation of the fluid inside the lung tissues. Okay, so here in the pulmonary edema, when you will auscultate for this one, you will get what you will get, the crepitus sound you will get here. Okay, yes, the bubbling sound you will get here, because the air you are inspiring which is going through the fluid, because there is inside the lungs there is fluid. Okay, so when you will keep stethoscope on the pleural effusion area, so here the lung tissue is end here only, so whatever the air you are taking here, it is not coming till this fluid. Okay, so because of that in the pleural effusion, okay, there is absent lung sound, we can say, or the diminished lung sound, we can say. Okay, so we'll get the absent lung sound or the diminished lung sound in the pleural effusion, and in the pulmonary edema we will get the crepitus sound because the air is moving through the fluid. Okay, so meniscus sign is classically seen in the pleural effusion. What it actually means, sir? Yes, let me discuss. Okay, so in the pleural effusion, classically, look at this one, this is a normal chest x-ray. Okay, this is the normal chest x-ray. Here the costophrenic angle is very sharp. Okay, because there is no any accumulation of the fluid. Okay, so look at this one, the costophrenic angle is completely blunt here, bacho. So the costophrenic angle is completely blunt here. Are you people able to see? This is the costophrenic angle, and here is the accumulation of the fluid is there. So the fluid accumulation with a crescent shape upper border, we call that one as the meniscus. Okay, so we call that one as the meniscus. Look at this one. So here there is in the accumulation of the fluid is there, and upper border is the crescent in shape. Okay, so this is what we call as the meniscus sign. Okay, the meniscus sign is classically indication of the pleural effusion. The most important question. Hope the explanation is very clear. Just let me differentiate between the pleural effusion and the normal chest assessment. Okay, so in the pleural effusion, when we will assess the chest movement, okay, so it will be a reduced chest movement in the affected side. Bacho, it's very common sense. Okay, so when I will inhale the air inside the lungs, my lungs should equally expand. Okay, so that is the normal. Okay, if there is accumulation of the fluid, means which is not allow the lungs to equally expand, so there is asymmetrical expansion of the lungs will be there in the pleural effusion. Especially affected side lung will not expand properly, so in the inspection when you will see the chest of the expansion, so one side chest is expanding, another side chest is not expanding, so that is what you call as the asymmetrical chest expansion. Okay, and decreased chest expansion on the affected side, so that is seen in the pleural effusion. Then comes to the tactile fremitus. What is tactile fremitus? So on the palpation, we have to keep our lungs, we have to keep our palms over the chest of the patient. Okay, and we have to ask the patient to say 99, 99, 99, 99 continuously. Okay, so when the patient will say the 99, 99, 99 continuously, we at that time we have to assess for the vibration on the chest. Okay, if the both side vibration are getting equally and normally, so that is the what we call as the normal tactile fremitus. Okay, so if there is no any vibrations, means that is called as the decreased tactile fremitus, which will be seen in case of the pleural effusion, and there is over vibration, there is excessive vibration, there is increased vibration, which will be seen on the pneumonia, a case of pneumonia, where we will see the increased tactile parameters, and in the case of the pleural effusion, we will see the decreased. In case of the pleural effusion also, in case of the pneumothorax also, hemothorax also, the decreased or the absent tactile parameters will be there. If the tactile parameters is increased, so that is the pneumonia. If tactile parameters means the vibration on the chest is normal, means that is normal. If it is increased, means pneumonia. Decreased means pleural effusion or the pneumothorax. Okay, so very very important. Then comes to the trachea. When we will see the normal chest, the trachea will be in the center of the normal chest. Okay, so if the trachea is shifted to the right side, means the left side pleural effusion or the pneumothorax happened. Okay, so the trachea is shifted to the left side, means right side pneumothorax, or the right side what we can say pneumonia happens. Sorry, not pneumonia, that's pleural effusion happens. Okay, so the most importantly, in the pleural effusion and pneumothorax, trachea deviates to the opposite side. Okay, so that is the most important. Then comes to the percussion. Okay, when you will percussion, when you will do the percussion, means when you will tap over the chest of the patient, normally in the chest there is air is there. Okay, so normally in the chest there is air is there. When you will percuss the chest, there is normally resonant sound will be comes. Okay, normally on the chest you are percussion, means there is the resonant sound will come. Okay, so but in case of the pleural effusion, here the air is not there, here there is the accumulation of the fluid is there. Okay, so when you will tap on the fluid, you will get the stony dull sound. Okay, so the most important, you are getting the stony dull sound. Okay, and on the palpation, you are getting the decreased or absent tactile parameters. On the inspection, there is reduced chest movements. Okay, so when you will auscultate for the breath sound, there is absent or decreased breath sound. Why I told? Okay, so here there is accumulation of the fluid is there, so the air will not come here, because this fluid pushed the lung upward. Okay, and here there is no lung tissue only, there is no entry of the air only. So absent or the absence or the decreased breath sound we will see in a case of the pleural effusion. Okay, so when we will see the chest x-ray, there is meniscus sign will be there, so that is the upper portion of the fluid will be in the crescent shape because of the gravity, and the opacity will be there over the lung, and the blunted costophrenic angle, so which is classically indicates the meniscus sign and the blunted costophrenic angle, so the opacity of the lung, and these are the classical indications of the pleural effusion. Okay, so let me make a scenario based questions to you people here. Okay, so the examiner will throw questions like this. When a patient comes to your emergency department with a shortness of the breath, you will examine the patient chest. On the on the inspection, the chest is asymmetrically expanding, means the right side chest is expanding more, and the left side chest is not expanding normally. Okay, so that is the asymmetrical chest expansion. And when you will check the tactile parameters of the vibration, so on the right side lung it is normally coming, on the left side lung the decreased tactile parameters is there. And so when you will see the trachea is diverted to the right side, and the left side pleural effusion is there, it's clearly indicating now. Okay, then when we will percuss over the left lung, there is the stony dull sound. Okay, because of the accumulation of the fluid, so there is a stony dull sound will be there. When we will auscultate the left lung, so there is decreased or the absent breath sound is there. So what may be your diagnosis here? So the diagnosis goes clearly as in the pleural effusion. Okay, so sir, same thing happens in the pneumothorax also, means accumulation of the air in the pleural cavity. So that time how do we have to differentiate, sir? Yes, when we will just see the chest movement, sir, there is a reduced or we can say the asymmetrical chest expansion is there, sir. Yes, both there is asymmetrical chest expansion is there. Tactile parameters, sir, same in the pleural effusion also decreased or absent, in the pneumothorax also decreased or absent, sir. Okay, sir. In the tracheal deviation, sir, same in the pleural effusion also shifted to opposite side, and in the pneumothorax also shifted to opposite side, sir. Then how we have to differentiate, sir? Sir, when you will do percussion, if you are getting the stony dull sound, means the fluid is accumulated inside, that is the pleural effusion. Okay, so when you will do percussion, you are getting the tympanic sound, means the empty sound. Okay, so bacho, look at this one. Here there is a fluid, means you will get the stony dull sound. Okay, if here is the air, means this is completely a empty space. Okay, there is no fluid. Okay, only air is there. When you will tap over the empty space, the tympanic sound will come. Okay, so if here the examiner given the tympanic sound or the hyper resonance sound. Okay, so hyper resonance sound usually because of the air trapping in the lungs, we will see in the COPD. Okay, so when we will do the percussion over the chest of the COPD patient, that time you will see the hyper resonance sound. Okay, because of the air trapping in the COPD and asthma. But if you are getting a tympanic sound on the percussion, means that indicating the very important, that is our pneumothorax. Okay, hope it is clear to you people. How to differentiate, I have taught to you people. Okay, so here is the next most important question, okay, which is coming in front of you people. So do read the question properly, perfectly. Just we have discussed already. Okay, what happens to the mediastinum in a tension pneumothorax? Yes, the mediastinum will still shift away from the affected side. Okay, so if the left side lung is affected, it will shift to the right side. Okay, so if the right side lung is affected, it will shift to the left side. Most important question. Okay, so here we are discussing the case of the pneumothorax. What it means, sir? Here the fluid is accumulated, we call this one as the pleural effusion. Okay, here if it is the excessively air is accumulating, we call that one as the pneumothorax. So very simple. Okay, so look at this one, a basic explanation of the X-ray. I told to you people, the fluid is white. Okay, and the air is black. If excessive accumulation of the air, so that gives a dark. Okay, so if the excessive accumulation of the air, that gives a dark. Okay, so look at this X-ray, bacho. This is the normal lung field. Okay, so in the normal lung field, so we are getting a light black color lungs. Okay, because of the normal accumulation of the air. So look at this particular image here. The excessive dark chest is there. So here it indicating the excessive accumulation of the air. Okay, so in the pleural space, which is completely air only, no any lung tissue. Okay, so the lung tissue is completely compressed by the air. Okay, so here the lung tissues went up, the lung tissues went up till here, and this entire lung is without, this entire thoracic cavity is without lung. Okay, and complete accumulation of the air only here. So this may happens in the tension pneumothorax. Okay, so at that point of the time, you will see the very dark. Okay, so very dark color lung, so which is clearly indicating a pneumothorax. Pneumo means air. Okay, thorax. Okay, so very importantly, so this is how we have to differentiate the pneumothorax X-ray. But so when we studied in the pleural effusion, there is the blunt costophrenic angle we have seen. Okay, but in the pneumothorax X-ray, we are undifferentiating. Okay, we are unable to differentiate the costophrenic angle because which is accumulated by the complete air only, so it is looking like dark only. We are unable to differentiate the costophrenic angle. Okay, whether it is sharp or blunt. Okay, but in the pleural effusion, we can differentiate that one very easily. Okay, so then comes to the very simple differentiation. Just we have discussed previously on the pleural effusion also. Here we will discuss on the pneumothorax also. Okay, just a moment. Normal should be symmetrical. Okay, so here I have told in the pneumothorax also there is decreased chest movement will be there on the affected side. Okay, so then comes to the tactile parameters. Normally it should be a normal vibration. If there is increased vibration, pneumonia, decreased vibration. Okay, so that is the decreased tactile parameters or the absent tactile parameters. We can, that indicates the pleural effusion or the pneumothorax. Okay, then comes to the percussion. Okay, normally we will see the resonant sound. If we are getting the tympanic sound or the hyperresonant sound. Okay, on this one, if you want to choose only one, the tympanic sound, choose as a first answer. If that is, this one is not there in the option, then go for the resonant sound. Okay, so most importantly, the tympanic sound we are getting means that is the clearly indicating the pneumothorax. Okay, so breath sound is absent breath sound on the affected side. Okay, especially in the tension pneumothorax. Okay, so that is already we have discussed in the pleural effusion also will get the absent breath sound, and in the pneumothorax also will get the absent breath sound. Okay, then comes to the trachea. Trachea will shift to the opposite side of the tension pneumothorax. Okay, so on the X-ray findings, okay, there is the absent lung markings will be there. So the dark lung we will see on the X-ray findings. Okay, this is how we have to differentiate the most importantly of pleural effusion and pneumothorax. Okay, so here is the next very important questions on the COPD chest X-ray. Okay, so just focus on this one. Which of the following X-ray finding is least likely to be seen in a patient with a COPD? That is the chronic obstructive pulmonary disease. Okay, but the main problem in the COPD is the emphysema. So what happens in the emphysema? Emphysema, there is the air trapping. Means the air will go inside of the lung tissue and air will get settle only there only. It will not come back completely because of the emphysema condition, that is the air trapping condition. So because of the air trapping, so there is in the increased anterior posterior ratio. Okay, so this is the anterior posterior ratio of the chest will be increased and it becomes a round. Okay, it becomes a round like a barrel. Okay, so because of the air trapping, so there is and the flattening of the diaphragm also there. Okay, so the flat diaphragm and increased anterior posterior ratio of the chest, so it is making total chest as on the barrel shaped chest. Okay, so barrel shaped chest, all people have seen the barrel like this. Okay, so the flat diaphragm here and increased anterior posterior ratio of the chest, so that is the barrel shaped chest. Classically we will see in a patient with a COPD. Okay, so barrel shaped chest appearance and it is there in the COPD. Yes, decreased vascular marking. And option C, the bulla formation. Yes, the air is trapping means there is chance of the bulla formation. Then which of the following X-ray finding least likely to be seen in the patient of COPD? Yes, the barrel shaped chest will be seen, a bulla formation will be seen, then decreased vascular markings means so we are unable to identify the vessels clearly and especially at the periphery of the lungs. Okay, so we are unable to identify the vessels clearly. So that is the also a classically seen in a case of the COPD, but pleural effusion is least likely seen. Okay, so the correct answer is the option D. Pleural effusion like X-ray we will not see in the COPD because in the pleural effusion there is different type of the X-ray. There is a meniscus sign and all. It will comes. Okay, so the entire differentiation is there. So option D goes to the least likely X-ray finding of the COPD. Okay, so hope it is clear to you people, right? So remember in the COPD, a flat diaphragm plus increased anterior posterior ratio of the thorax, which makes the thorax to barrel shaped chest. Okay, so hope it is completely clear to you people. And here is the most important and already discussed question on the cardiomegaly. Okay, so cardiomegaly on the chest X-ray is typically diagnosed when means yes, normally I told you people. Okay, so this particular cardiac portion should be half of the thoracic portion, right? So the ratio should be less than 0.5. Okay, if it is going more than 0.5 means there is a big heart. Big heart means there is the what we can say, there is cardiomegaly. Okay, so that is the very important classical things you people have to remember to diagnose the cardiomegaly. That is the cardiothoracic ratio is more than 0.5. So in the posterior anterior film, so that indicates that is in the cardiomegaly. Okay, so cardiomegaly will be diagnosed by the cardiothoracic ratio. Okay, so look at this one. This is the thoracic portion. Okay, so this is the cardiac portion. Okay, so look at this one. The cardiac portion started from here to here means which is more than half. Okay, it is more than 0.5. So that is the clearly indicating the cardiomegaly or the big heart. Okay, so these are the very important X-ray. How to identify what is the differentiating key characteristic feature. Okay, but so there are thousands of the questions are there in the interpretation of the X-ray, but I have thought to you people that is which is most important to you people. Okay, so hope that today's session is very beneficial to you people, and all others related questions we have discussed on the chest related diseases. Okay, so hope it is clear to everyone. And in the today's session, so we have discussed the X-rays. Okay, then we have discussed the some very important sign in the X-rays, some USG, some barium swallow and barium enema findings. Okay, so these all are the very important findings. if any questions which wants to come in your exams from the radiological science, means definitely questions will comes from this box only. So it will not go out of my explanation extension. Okay, so it will be, the questions will come from this particular explanation only. Okay, so hope the thing and everything whatever I have explained today is very much clear. Okay, so and you people know that we are having a very beautiful plan of the Norcet 9. Okay, Norcet 9 test series. Okay, here the name of the Norcet 9 test series is the Navagraha test series. Here we are giving a daily live exam. Okay, from morning 6 a.m. to the 11 p.m. night. Okay, at the 11 p.m. night, at the 11:30 night. So you people will get the all India rank, all India rank. Okay, so the most importantly, you can give this particular test anytime, anywhere. Okay, since from morning 6 a.m. to 11 p.m. Okay, so then you can next day you can give the multiple attempt, and you can same day immediately after submission of the test you can revise all the questions with clear rationale. Okay, so people will self assess how many questions we are correcting, how many questions we are getting wrong. Okay, so where this is available, means this is available in the master nursing classes app. Okay, so the link I have given in the description box, and there are the free quizzes also going are running in our WhatsApp groups. Okay, so for the upcoming KGMU GMCH exams, so if you want to become a part of that one, I have given the link of the uh, what we can say WhatsApp chat. Also I have given the link to join there. Okay, and app link also I have given to join the Norcet 9 test series for the upcoming exams. Okay, so if you want to be a part of that one, so please do download and enroll today. So hope the today's class is helpful to everyone. Thank you so much for staying till the last and coming out of the crowd. Okay, so this is how we have to study to come out of the crowd. Okay, hope it is clear to everyone. So we'll discuss next questions in the next sessions. So tab tak ke liye, jai hind, jai bharat, stay positive, keep studying. Love you all. Bye bye.